Okay, welcome everybody to this research seminar. I think it's the last for the season. The snow is falling. But we're very happy to have Erik Wengström here. We're going to talk about intended and unintended consequences of financial incentives. And Erik is a professor of economics at Lund University and a fellow at Hanken School of Economics. And received his PhD in 2007 from Lund. My thesis on communication in games and decision making under risk. And you have focused your research on how people behave in economic and financial contexts, and lots of different topics, decision making under risk, cooperation and communication in games. But lately, and that's I think maybe unfortunately why we know you, is that you've been written about COVID-19 vaccination and using monetary incentives in that context. And that's, I think, is what you're going to talk about today too. So very welcome. The floor is yours.
Yes, thank you very much for inviting me. And indeed, this is what I'm going to talk about today. I'm going to talk about intended and unintended consequences of providing incentives. But just let me give a little bit of a backdrop. And I promise you, only the first 4 slides are going to contain nice pictures. And we're going to see tables and regression output. But I mean, we all know, and especially some people in this room know that, you know, the pandemic was brought a lot of attention to behavior. It brought a lot of attention to trying to change people's behavior. And this was in a context with a lot of risk involved and a lot of social aspects involved. It was not only about caring about myself, but also caring about others. So, and as sort of you alluded to, I worked on a lot of different topics before, and that includes how people take decisions under risk, but also how people behave in situations where there are consequences for others. So it seemed like a very kind of, as an academic, an interesting situation to study human behavior. And this is basically what we did. We started looking at, you know, what factors are actually driving health behaviors. So together with the same set of co-authors, almost as the rest of the talk today, we looked at what are driving health behaviors, or how can we, you know, explain or try to understand who are following recommendations, who are, you know, socially distancing and so on. And these were kind of, in a sense, very simple associations. So we associated health behaviors with prosociality, for example. So people that were more prosocial were also more likely to socially distance and so on. So that was kind of the first wave of studies we did. And this kind of leads over to the next question, of course, is how can we actually change behavior? How can we promote healthy behaviors in general? And in some sense, COVID-19 pandemic provides kind of a test bed for this. There are many different solutions, including, you know, regulations, mandates, and so on. There are nudges around. You have also monetary incentives, and that's going to be kind of the talk of today, where we zoom in on, first of all, some different interventions that we have tested how to improve health behaviors, and that'd be nudges, which are more like information trying to persuade people to behave in a certain way without changing incentives. And we also introduced then financial incentives. But this is, you know, quite controversial. People, it hasn't been, you know, it has been introduced in certain places, but typically not in most places. And one of the concerns is, of course, that this might lead to some unintended consequences, kind of crowd out social motivation and so on. So that's going to be the second part of the talk, trying to say something about that. What are those, or what are the potentially unintended consequences, and can we somehow estimate those? So this builds on a series of studies that we conducted over the last 2 years here in Sweden, and it focuses on vaccine uptake. That's natural for several reasons. Well, this is at the end of the pandemic, so it's kind of the most relevant health behavior. We also have very nice data on it. Thanks to the Folkhälsomyndigheten, we can get, you know, real outcome data rather than relying on survey or people telling us what they are doing or what they claim to be doing. And this is joint work with 5 co-authors: Paul Campos, Mercado, Armando Meyer, Florian Schneider, not the Kraftwerk Florian Schneider. This is the economist Florian Schneider, I'm sorry, but Devin Pope and Stefan Meyer. And I put Paul and Armando and Florian bold here because they were really, the driving forces of these projects, so they should have the most credit for it. Okay, so first question, how to promote health behaviors? And we thought about different solutions, thinking about providing information. Maybe it is really the fact that people don't understand how good these vaccines are, or at least how good we thought the vaccines were at that point in time, well, let's say. I mean, the evidence were pretty clear that these were effective vaccines. They had very low risk. So can we just sort of convey this information in a more clear way? That could be one solution. Another part relating to the fact that we saw earlier that more prosocial individuals are more likely to behave well or behave, cautious in the pandemic. Maybe we can take leverage of this somehow and promote or kind of put emphasis on the sort of positive externalities, as we think economists like to call them. That is, the sort of impact, the positive impact it has on others if you get vaccinated. Maybe we should try to highlight that somehow. Maybe it creates an additional motive for people to go and vaccinate themselves. Because one problem here is, of course, as always with externalities, is that, I don't reap the full benefits of my actions because this has positive effects on others. And the third thing, which we actually throw it in a little bit at the end, and it was kind of a lucky throwing in at the end kind of change to the design. Maybe we should also try incentives, because people were starting to talk about incentives. And this is then what we did during the first round of vaccinations in Sweden, and this was published about a year ago now.
In Science.
Yeah,
Not bad.
Science. So it was a very, let's say, a lot of attention to this issue at the time being, and this was, I think, one of the first studies that did this in a sort of controlled way with real vaccination uptake as the main outcome variable. And it was an RCT, that is a randomized controlled trial, an experiment we did in Sweden. We had around 8,000 people involved. It was during May to July. So that was really at the phase when a vaccine was opening up for the ones between 18 and 49. So we were the only one in Sweden that were happy that the whole process was a little bit delayed, because we were running against the clock here with ethical approvals and so on, right, to get this in place. But so the trial here started at the start of vaccination for each group. So these were on previously unvaccinated people. And this is pre-registered. That means that before running this, we write down a report. What are the hypotheses and what are the kind of statistical analysis we want to do in quite some detail? What are the control variables? What are the econometric or statistical methods, and so on, to kind of limit ourselves a little bit when it comes to just running 1,000 regressions and finding something that's significant. So the question is simple: can interventions increase vaccination uptake? How many heard of the study before? Some, yeah. Yeah, every week, yeah. So how did we recruit? So we used an online survey. That's one of the survey companies, Nordstat. And they gave their social security number to us, or actually not to us, to another company we were collaborating with, so we didn't have the social security number. And they answered questions on sociodemographics and COVID attitudes and personality and economic preferences. By economic preferences, we mean things like risk aversion and altruism and some things might not be purely economic preferences, but things that are more like as a preference rather than part of your personality. And then we introduce different interventions, randomize these into these different groups and measured their intentions, so whether they intended to take the vaccine. And then after that, a few months later, we linked it up with the vaccination record by the Public Health Agency. So this was basically the setup. We had these participants, they were randomized to different groups. So we had a control group which basically received an encouragement. So the control group said, we encourage you to get vaccinated. And then we had another incentives group of 200 kronors, which they received if they were vaccinated. And we were checking that in the register. So this was checked by the data. And then we had these other nudges. So I was mentioning that we wanted to kind of underline the sort of social aspects. So that's one thing we did here. We had a treatment, and we didn't just want to provide information. We wanted to make it a little bit hardwired. So we asked them to write down 4 names of people, a list of loved ones that you kind of care of that would be protected, like my mother or my friend who is in a risk group or something, to make them really stop and think a little bit. And another treatment, we asked them to this is the think treatment. We asked them to give an advice or an argument to convince someone else that are skeptic. And this was going to be implemented as well. So we were going to show these to someone who were skeptic, at least with some probability. And then we had an information, and that was, providing information about the risks of the vaccines and so on. And this was in the form of a quiz. So they had to answer some questions again to make it a little bit more heavy-handed, instead of just providing information that people click away. We wanted them to really stop and think about this. So this was the main kind of setup, and we had, after 2 weeks, treatment-specific reminder. So they got a reminder of what group they were randomized to, and after 4 weeks, we had another specific reminder. And in addition, we actually had a treatment with no reminders as well, because in the behavioral science literature, the reminders have been, promoted as an effective way of changing people's behavior. And then the main outcome here was whether they got vaccinated within 30 days of the survey or 30 days after the vaccine were made available to them. So this is what we look at in primarily, and it's also what we look at in terms of payments. So those that qualified were those that got vaccinated within 30 days. And this is what happens. I should note that this doesn't start with 0, but start at 65. But what we see is that in the control group, around 72 or 71.6 got vaccinated, and it jumps up to around 75 in the incentivized treatment. So it's not huge, but if you think about, the fraction of those, let's say 30 that are not vaccinated, it's still quite sizable. So reaching more than at least 15% of those that you could reach there, right? Or even more. But we also see that the nudges, this is all nudges together. These are the separate nudges. Yes, maybe they do something, but it seems to be somewhat less. And reminders.
So all nudges together, that's without the incentive?
Yes, so this is the incentives only. So they were in one treatment. So yeah, we don't refer to the incentive condition as a nudge here. Okay. So this one is the aggregate of the 3 different
And you didn't have anyone with nudges plus incentives? No,
then it would be, we didn't have that. And this is, if we would just merge the groups, of course, it would end up somewhere in between. But yeah. That's another possibility. You could think about interaction. So maybe if you have incentives and something else, then it might be even more powerful. We don't know that. This was just the raw numbers. We also do some regressions. So these are from ordinary least squares regressions, where we have just the treatment effect in terms of percentage point change in vaccination uptake. And we have the filled marks here. That's the actual vaccination uptake, and the other ones are the intentions. So we can see that intentions are, people are a little bit more optimistic or exaggerating a little bit the extent to which, or looks they were going to take the vaccine compared to the actual vaccine uptake. So when we are looking at the actual vaccine uptake, the only treatment that had an effect was actually the monetary incentives. There is the others are positive, except from the others were positive but not statistically significant, right? So that's
Sorry, another explanation.
Yeah.
No reminders. So,
yes.
So
But the thing is here, reminders didn't play a role here. It was a little bit surprising to us, but
yeah,
this shows that yes.
I'm thinking on that. So you have people with nudge 1 and no reminder, people with nudge 2 and no
No,
reminder.
it's just no reminders. So that's like the control treatment.
Control and no reminder.
Yeah.
Okay.
So this
so
is
all the ones with nudge incentives, they had reminders too.
yes. So these all had reminders, and incentives had reminders too.
Right. Yeah, it would be interesting to see incentives without reminders.
Yes, I mean that could have been. Probably, not so big effect, but probably weaker. Yeah. So that's. Shouldn't jump into conclusions, but or speculation. But one interpretation about why this works is that it kind of gives a sort of a tension effect to the whole thing, right? And then you get reminded, and it kind of I have 200 kronor waiting for you. It's like, it's kind of brings your attention, and that probably helps by providing reminders as well. And we do have, this is not for you to try to see, it's just showing that there is heterogeneity in vaccination uptake. So we see that people that are college educated, higher income, employed, and with a non-immigrant background are more likely to take the vaccine in the first place. So this is just correlations, right? We can also look at our kind of preference measure. So we have altruism, and whether you are the risk preferences, patience, trust, procrastination, and norm adherence. And we see here that trust, for example, is a pretty strong driver of whether you take the vaccine. Yeah. As always, so that's and also norm adherence. So that's a question whether you try to do what is expected of you in different situations. So it was clearly kind of the norm to take the vaccine in Sweden, and some other measures like reciprocity and are also significant. But that's showing that yes, there is a correlation between uptake and these kind of socio-demographics and preferences. The question is, does this interact with treatment? So is there differential treatment effects? And the answer is somewhat to our surprise, no. We tried to look at this in different ways, and this is just treatment effect for different groups. So these are, for example, aged below 35 or above. It's pretty much exactly the same, female, male, college, no college. Yeah, slightly lower perhaps for high CES, but socioeconomic status, but it's clearly not significant differences we're talking about. So it's somewhat to my surprise, this effect was kind of uniform across the board when it comes to people's background characteristics, and also when it comes to sort of their preferences. So this was basically the paper we published in Science. And it was a specific situation. The vaccine was totally new, and COVID was still much, on the radar and the focus and everything as well. So we might ask the question, okay, does this carry over, at a later stage of the pandemic when it comes to sort of example the booster shot and even for other types of behaviors? And does it matter how we give those incentives? Now we paid a fixed fee of 200 kronor, but in many other places they introduced like lotteries in the US in particular and so on. So that's what we wanted to address in a second paper where we look at the booster shot. So this was from earlier this year, where we again, the same set of co-authors, use kind of the same setup, elicit preferences, and we randomly allocate subjects this time into these groups. So we had a control condition. We had the same as before, guaranteed condition. We had one with lottery condition where they had 1% chance to win 20,000 kronors. And this is all paid out. So we had about 5 or I don't know, some lucky winners that got 20,000 kronors. And we had a donation condition, so 200 kronors to save the children. And finally, we had a choice condition. So maybe what works best if you can choose your own incentive, because some people might dislike, getting 200 kronors. I mean, I don't do it for the money. I don't want to pretend I do it for the money. So maybe it's more efficient to give, 200 kronors to charity, perhaps. So this was our reasoning. And we also thought that maybe, if we pick up these preferences, like social preferences, maybe that's more effective for those that are very pro-social. Maybe the donation will work better. Maybe for those that kind of like to take risk or like to gamble, they would prefer the lottery. So potentially, we could target these interventions to different people depending on those background characteristics. So that's one of the thoughts behind this design, that we measure preferences and we have different interventions, and potentially we can have this kind of optimal policy targeting. And the setup was the same. We matched with admin data. We had about 5,000. Okay, so do you think it works, have a bigger effect on the booster shot to pay people compared to the first round?
When you say pay people, you mean the same?
Yes, the 200 kronors, yes. Yes? Yeah, you're right. It's actually quite a bit bigger. So this is the control. Okay, the average level is lower here. 32, but here it jumps up to 44% if we pay people 200 kronor. So it's like 12 percentage points. And we also see that the lottery condition also boosts uptake a bit, and also the donation, but less. And the choice condition performs about the same as guaranteed conditions. But this is, when it comes to this optimal targeting of policies, it doesn't really work so well yet. We're working on it. We're trying with different machine learning, algorithms to get it to work. But the problem is that this is just better. For most people, it's still better. So it seems like the best thing you could still do is probably just to throw everyone into the guaranteed condition after all. Even though when we ask people in the choice condition, those that are more pro-social, they are indeed more likely to go to the donation condition. It doesn't help us from sort of a policy design perspective, as far as we can tell now, to try to target the different interventions to different people. Yeah, it's a little bit surprising. So we are trying to actually, in some of the simulations, we don't really know why yet. I mean, it's even performs worse than just, putting everyone in here, or, putting the, let's say 80% here and 20% there. There is something going on here, which is, we're not figured out quite yet why that's the case, but we're working on it. But the main thing is that just that this one is dominating for most people, depending on their backgrounds. It was a little bit surprising to me too. I thought the donation would work for some people more, perhaps. I mean, you feel like.
If you still work on this, it would be fun to try the classical way to give people esteem. That is some kind of medal or something like
yeah.
that.
Badge something, yeah.
It
Yeah, it could be.
you do a lot with, when you donate blood or something like that, you get this.
Yeah, I think maybe some discrete thing like that you can kind of implicitly show that you are a good person. Not too explicit, because people would be a little bit afraid of that. Yes, we are thinking about doing some stuff now in Africa. So we are going to continue this research, but in a totally different setting probably. So this is sort of summary so far. Incentives seems to work in this situation, at least here in the short run. Nudges here for information and deliberation or focus on the social impact did not have a significant impact on vaccine take-up. And we also saw here in the last slide that guaranteed payments outperforms lotteries and donations. Yet, many remain quite skeptical. And this was a lot of, skepticism. So this was me sitting in my cabin in Ronneby, and this was before we didn't even have any results, so people were so, interested in, ended up in science because people thought this was so weird to pay people. And this is probably the most boring interview I've ever done because I couldn't say anything because we didn't have any results. Yes, we are running a study. And it just shows that there was a lot of, skepticism around this whole issue. And I guess anyone who worked on this kind of topic I received a lot of letters from people that are very skeptical and emails. And why is that? That's what we are looking into in the last project. What are the kind of potentially unintended consequences? So this is a next paper. It's actually coming out in Nature pretty soon. So it was a good payout from this project. So we try to kind of summarize why is this? We do know that monetary incentives are widely used to encourage healthy, or widely, maybe a little bit exaggerated, but they are used. And we just saw this example of ours, but there is also in other settings where they can offer trigger initial change also in blood donations in some studies, perhaps not in every, but there is evidence that they do help people with exercising. I actually have another paper on exercise where we also show that this could be quite big effects from providing different types of incentives, clinical trial participation and so on. But there is this large, of course, and long-standing literature in the social sciences and philosophy and public health, medicine and so on, warning against the use of financial incentives because we think they might have this kind of unforeseen or negative unintended consequences. But when you really look at, the evidence, it's not that much, controlled evidence on this topic. There's a lot of skepticism, a lot of speculation and so on, but controlled evidence trying to measure these things, there is still not much around. So what are the kind of negative unintended consequences that we can think about? The first one is probably this idea that it might crowd out intrinsic or prosocial motivation, which could result in less healthy behavior when we remove payments, or actually some people would claim that it would result in direct negative effect, on vaccination uptake because it would crowd out social motivation. But that we do not find. But there could still be, these kind of effects once we remove the incentives, right? And it could also be, a general deterioration of moral values. So we have researchers like Bowles saying economic incentive signals that selfishness is an appropriate response. So that could be one story. We have, of course, Sandel's book, What Money Can't Buy, argues that it kind of erodes people's sense of obligation or diminishing the sort of spirit of altruism. And we showed in this very early paper that prosocial motives are important driver of COVID-19 behavior. So there is a scope for crowding out this kind of intrinsic motivation at least. So that's kind of one strand of the literature that suggests that we might have unintended consequences. Another argument that has been raised is that, well, maybe the signal that this is something dangerous to do. Say, hey, they need to pay me, in order to do this. It must be something fishy going on. It must be dangerous. So that's another line of arguments that has been raised, that it kind of provides a signal. And then there is also the idea of kind of coercion, or that payments undermines people's sense of self-determination. So I would say if you pay a big amount, maybe there is more bite to this argument, that people might feel forced to do it. I cannot resist saying no, so it kind of makes me forced to do that. Yeah, so that would be my counter argument to say, okay, 200 kronor, you're not really forced to do it. But still, this is argument that we heard a lot, when presenting these studies. And there was this heated debate, even actually in the science. the same issue as we were publishing our. They had some a philosopher that was asked to write, a comment, kind of downplaying or problematizing, the issue a little bit in the same. Pardon? Yeah. Yes, there is pros and cons, or different stand. Let's say it's heated on both sides in that case. And studying this kind of consequences is kind of difficult from an empirical perspective. Typically, that's what we call identification challenges. There are some challenges in trying to identify these effects, and we would like to have, a situation where we have randomly offered payments, and we would like to have data on people's behaviors, morals, perceptions, and feelings. And this is what we try to do in our study then. We have the randomness from our previous science study, and we can measure a lot of these things in an additional survey to these people. So we can follow up those people again and try to pin down, did something happen when it comes to their views on, the riskiness, or on, the moral motivation, or those kind of, did they feel coerced to do this when they were paid? So that's basically what we do in this study. So this is just the old stuff I told you about. That's the first study. And then we can look at second dose uptake. They were not incentivized to take the second shot. So that would be kind of the first outcome we can look at. If it kind of, you're no longer paid, I will just stop doing this. Then you would see a negative effect, right, from being paid. So that's kind of the first test we can do. And then we do a survey with these participants of this original study. And we ask them about health behaviors, morals, perceptions, and feelings. And luckily enough, we got relatively high response rates. So we have 64, and most importantly, it's kind of the same. So we invite the control participants and those that got 200 kronors. And we get approximately the same, or very closely similar response rates in these two groups. And as I said, we pre-registered all the data collection and data analysis. So what you see is what we kind of wrote down and promised to do before we actually looked at the data and ran the study. And we had 3 primary outcome variables. That's then going to be the second dose uptake, and then morals and safety perceptions. And a battery of secondary outcomes, which we can also look at. And when it comes to the results, this is the effect of past incentives. So these are separate regressions. Each of these lines is, regression on whether you were, or whether this participant were part of the 200 kronors treatment group in the old experiment. And then we run a regression with controls, including, some socio-demographic controls and age and regions and so on, effects. And then we see, okay, what's the effect of being paid in the first round on taking the second dose? And it's positive, not significant, so it's kind of small. But if anything, it's not negative. If anything, it's more likely if you were paid to take the first shot that you also take the second shot. And it also goes for whether we look at how quickly they take it. It's quicker, not significant. Whether they take conditional on taking the first dose are more likely to take the second dose, and whether they are willing to take the third dose. All of these are small in effect size, and the only thing that kind of pops out as significant. So these are confidence intervals, and this is the coefficient estimate. They are all small, and if anything, the only thing that's significant is actually positive here, in the sense that they are more likely to click on or ask us to get a reminder for the third dose. But and what is small here? So there is in the literature, typically this is measured, I should say, as a changes in standard deviation of of these behaviors, and then we should what is typically considered to be, a small effect size is somewhere 0.2 of a standard deviation. So we can see that all these effects are smaller than 0.2, so they are considered to be small by sort of standards, how you think about effect sizes. And we also try to see maybe this could kind of carry over to something else. So we ask them questions about flu shot and blood donation as well, and we see that there is just no effect on whether you are more likely or less likely to donate blood, whether you were paid in this experiment. And we have, so that's kind of behaviors. So what about the morals? We try to measure those, and we do that by asking questions. And we create an index for moral and civic responsibility based on 3 questions that are asking them, I'm willing to take the personal cost of getting a COVID-19 vaccine, in terms of time and discord for the greater good of society. So it's kind of playing into this kind of civic duty of taking the vaccine. I think people have a civic duty, a moral obligation to get a COVID vaccine, and not taking the COVID-19 vaccine is generally viewed as socially inappropriate. So these were some questions we come up with basically to try to capture the spirit of this critique or spirit of what could go wrong here in these aspects. And then we create an index based on these 5 questions. So it's one variable we look at. And we also had we're economists, so we also like to have some incentivized stuff. So we asked them to divide 100 kronor between themselves and something called the Global Alliance for Vaccine and Immunization. So that's a charity that collects donations to provide vaccine in kind of in areas with limited access. So that was also sort of another measure. So they were not all played out, but with some probability, this was actually implemented. So they either got what they kept, or they the remaining were sent to this charity. So we sent money to this charity according to the selected participants. So this is another way of trying to measure, morals and the civic responsibility. And we had a similar question where we had another charity that attempts to increase vaccination uptake by paying people for getting the vaccine. And these were kind of then again regressed on the impact of treatments in the first wave, first study, and we see that there is no significant effect, and they're very small, closely. So there seems to be no impact of being paid here on the way they answered and the way they decided to donate, or whether they decided to donate for vaccination or payment for vaccination. So that's kind of the first potentially unintended consequence here we're thinking about. The other one is perceived safety. Recall that argument that maybe this kind of payment signals that this is dangerous. So let's look at people's perceptions about how they perceive the vaccine. So we had 3 questions here in general. COVID vaccines are safe. Another one, I'm worried about the side effects. And another one is about how effective they are. So COVID-19 vaccines are highly effective at protecting my health. Another question we had is whether vaccines were generally safe for children. That could be another potentially spillover if this signals that vaccines in general is something that we need payment for. They might be, raise the skepticism towards vaccines, also the measles vaccines for kids. And we also had this trust in vaccination provision index, because that could be another potential concern, is that, you lose trust in the pharmaceutical industry or in the researchers or in the Public Health Agency of Sweden, because they were somehow involved here, so that might, lead to bad outcome for them. And it's getting a little bit boring, but there's just no effects, and they're really, quite tightly estimated around 0. And the last point, this kind of idea of self-determination or coercion and so on, we tried, and some other effects we tried to measure using questions like whether this was ethical, financial rewards of vaccinating or unethical. I would support the introduction of monetary payments, would be, another thing. And we have trying to, see whether people felt forced to it. We asked the question whether they regretted the decisions you made. And also another concern is that, people might get rushed into this, so they don't have time, to collect enough information and make up their, mind whether this is something they want to do if they are, paid. So that could be another argument. So we try to measure that with this question. Did you gather enough information to feel well informed about the benefits of the vaccine when you decided? And lastly, this is the last question. So I'm gonna bore you with is, whether they were feel forced to take the vaccine or not take the vaccine. So that's more directly trying to measure this feeling of coercion. And again, we see just nothing. So that's basically the punchline is there is nothing in the data. So it's nice to see that it's actually possible to publish a null result paper. But referees are gonna raise a lot of concerns with this kind of stuff. So we think, okay. I thought it was for me. I thought it sounded like it was a little bit to me, but so one question is, can we rule out small effects? Maybe there is still some small effect, but really if we look at these coefficients estimates, it's like the mean coefficient estimate is 0.0009 of a standard deviation. The largest negative effect is minus 0.04. That's the largest negative effect we can say. So a small effect is typically considered to be 0.02, and we can actually test and we can reject with this kind of equivalence testing that we don't have any significant, or we can reject that we have a negative effect of 0.2 or less, for any of the outcomes. Do we have enough power? That could be another concern. And what we can say is what we do have 80% power. That means with 80% chance, we would detect a negative effect of minus 0.12 standard deviation, according to the standard 5 percentage points level. So it's quite well powered. And another issue that was raised was, okay, so you provide the incentives. That's a big difference compared to you as a researcher do it. It's not, the government. And of course, if you provide Swedish data to, an international journal, Sweden is different. It's a crazy country, it's high trust, and we cannot, translate those findings to a real population somewhere. Maybe not expressed so boldly, but that's what sort of is often the sort of implied meaning of it. So we try to look at this in different ways. For example, we can look at this skepticism by looking at categorizing people whether they are hesitant. And that we do by looking at their perceptions of the vaccine safety, whether they worry about side effects and worry about needles. So we measured those things. So we can group people according to whether they are skeptical or not. And without going into detail, you see there is not many stars here or no stars. Basically, it just says that whatever we do, we look at quintiles, we look at a median split, according to these groups, there's just nothing. So this effect, there is no effect even for those that are the most hesitant in our sample. And that goes whether we look at, age, gender, income, education. So there is not, any heterogeneous treatment effects here indicating that it's just because people are not skeptical. Another thing we did was, okay, let's say maybe people react differently if they learn that these were offered by government instead of researchers. So we do sort of what is referred to as an information provision experiment with a general sample of Swedes here, 1,000, and where we have 2 treatments. In one of them, we tell them about our study, and we say that a team of researchers participated in the implementation. The other says the Public Health Agency of Sweden participated, or they were not really participating, but we say it in Swedish, I think, bidrog till datainsamlingen in this incentive program, to not be lying to people, but they were involved to some degree. And then the question is, okay, does this actually impact people's perception of the vaccine? It's a little bit far-fetched. So in a sense, this is what you do to please, the referees, perhaps, rather than you believe in it. But this is one way to tackle this issue, right? To provide one group with information about researchers providing incentives, and another one with the Swedish Health or Public Health Agency. And outcomes here were, questions about vaccination uptake, morals, and safety perceptions. Again, pre-registered and everything, and this is then whether they were in the treatment where the researchers offered the incentives in contrast to the government, and we see that, there is nothing here again, So it doesn't seem to matter, at least in using this design, whether we have the government or the researchers providing the incentives. The other question, whether Swedes are crazy, we need to get some data, and so we need to get some data from the US, and how do we do it? Yeah, that's what they want, low. Yeah, so how do we do it? So we took advantage that there were in 24 US states, they implemented vaccine incentive programs. So again, we did like a information provision experiment. So that's an online survey, basically, with 2 treatments group with 3,000 participants in the US. And in one group, they received information that their state government implemented COVID-19 vaccine incentive program. So this was not that well known, so we could shift their awareness of this fact. That's kind of one underlying assumption here, that we can actually affect their awareness of this. So we measure that, and we can see that the ones in the treatment were more aware that there were these kind of incentive programs in place. And then again, we measure these vaccination uptakes, moral and safety perceptions. And these were not measured directly, because then we might think that there is some direct spillover. So they were measured in a sort of survey a few days later. And this was, again, pre-registered. And as you see, again, there is just no effects. And if anything, there is tilting. If anything, they're tilting more towards the positive effect than the negative effect of getting informed here about that there was this incentive programs in place. So that's the last slide. Not the last, that's the last real slide. I'm just going to wrap up, saying that we have shown, I think, that financial incentives in this particular context increases vaccine uptake. And there is this large literature warning against the use of financial incentives. And we try to measure those, and we find that at least our small, kind of modest stakes have no unintended consequences in this setting, of course, with all the caveats and all the other things that we should have in mind, that this kind might be context specific. But thanks. That's the last slide.
That's the last one. Thank you very much. So we're going to the question and answer period, and the first half hour will be recorded. And for you online, we use the chat function as usual. So write your question in the chat. Also write your discipline, since we like to field questions from different disciplines. So Olle och Valeska. So then we start with Valeska.
Cool, thank you. This was very interesting. Without knowing the literature, I might say, I would assume that behind a lot of these worries about these unintended negative consequences lies some slippery slope argument. So you might think, yeah, sure, as long as these incentives are like only in a few cases, maybe vaccine and blood donations, we don't see these effects. But if we start implementing a system where we always pay people for the health behavior that we wish them to show, these worries become a lot more pressing. And I think we have to be careful with these kinds of arguments, because it's pretty speculative as well. Just wondering what you think about that.
No, I think you pinpoint. I think my general concern or my general weakness with this study is very much what you say. You know, this is a one-point intervention.
Exactly.
I think that most people that are critical, they don't want to live in a society, as you allude to, where everything is kind of paid, because then that might start to crowd out those rare behaviors or those behaviors that are not paid. So I definitely agree. I think it's one thing to implement this in an extreme situation, let's say the COVID situation or something. Whether we would like to do it more broadly in many situations, that's partly a different question. I agree. Yeah.
I could follow up on that because that was my question too. I mean, norm change takes quite a long time. So, I mean, I really like your first study, but the second study I thought, I mean, you're not going to see an effect from a one-time intervention. I mean, if you look at this more fundamental changes, you have to have it over a long time. And I guess you're aware there are some studies, maybe going through, a business program might change your becoming a bit more self-interested, but that's at least 3-4 years. But the change norm for one-shot intervention seems. So in one way, I don't think it meets the critics at all. This more sane.
Well,
critics.
I partly agree. As I said before, I partly disagree, because many of those critics, they were critical also for paying, in this one-shot environment, because they said it's going to signal that it's dangerous and so on. That was arguments raised.
You mean the one-shot that using it just during
Yeah,
the COVID
using it in
pandemic?
COVID, we should not do it because people will take up less vaccine
Okay,
because
so
it
that
will signal.
argument-
So that argument, I think, is ruled out basically in the first round, but
Yeah.
we could also see, we can provide some bounds probably on these kind of arguments. We can say that, yes, if anything, it will take higher stakes, it will take a long run perspective, but we should not be worried if we have like a crisis situation to implement these once at least. I think
Almost
this is,
But I mean, the titmost on that kind of arguments for blood donation, it's a more an idea of having it for a long run and on a broad
Yep.
senses. But of course, I don't know how to study that. 'Cause
no,
I'm not the
I
full
agree. I
student,
mean, this is something we need to think deeply about, and that's, I guess, a general critique towards a lot of these kinds of studies, which are typically, implemented in a short span, and we are, in a sense, to get identification, we are often bound to short-run effects. I mean, that's one of the problems, or it's not bound, but it's much easier to measure. But
I wish Pontus was here because he might be able to tell us. Pontus Strimling,
Yeah.
who studies norm change. Karim.
Yeah, just to follow up on that, I think that it might be interesting to study the effects on in Brazil, for example, because they have financial incentives for health behaviors that are ongoing. And interestingly, the reason they have financial incentives in that context, as far as I know, is not because they wanted to encourage people to do these things, but because that improved the social acceptability of social transfers among the middle class. So that's another aspect to take into the consideration. Maybe it's not such a bad outcome that people expect to get paid for healthy behaviors if that simultaneously increases the political acceptability of social transfers to poor people. mean,
yes, but I guess
it's
the rich
relevant.
people also get those transfer or payments, or yeah.
Sure, but they can still be progressive. if
Yeah,
they-
yeah, no, that's could be a good way of implementing or killing two birds in one stone. Perhaps you could introduce this as a transfer, and yeah.
I thought Karim's idea where you could study Brazil.
Yeah.
You can go to
Yeah.
Rio. It's
I
nice
mean,
to-
that's interesting. I mean, that would be a nice. But I guess the problem is that it might not be randomized. I don't know the details, but I will definitely look it in. I mean, take a note and see whether, because that's what we always are especially interested is if you could get some sort of causal identification, right? But it's true that it might be interesting in itself to study the case.
Okay, Olle.
Yes, thank you. There must be studies about people's attitudes or reactions to incentives regarding health behaviors more generally, I guess. And I'm curious about if there are any interesting differences between how people react to incentives in the COVID-19 case in particular, and how they react to incentives regarding health behaviors more generally. And also whether if there are any differences between how people react to incentives regarding health behaviors compared to how they react to incentives regarding non-health behavioral choices. If there's anything like interesting in particular about the COVID-19 case, or if these numbers or results that you've given us are fully in line with what is already known about how people react to incentives.
Yes, I think that's a very good question. I mean, we try to look at it a little bit on this first slide. I pointed to different studies, going in the same direction. Those were mostly, in the sort of health domain, and there I think it's, if anything, it's kind of in line with what we find here. But of course, there's this differences between context and studies. And when it comes to trying to find out how it affects sort of these morals and unintended kind of attitudes, there is not that much studies as far as we know of, that looks more specifically on this issue. It's more on this kind of first direct impact of incentives. But if anyone knows of careful studies that also try to measure those kind of unintended consequences in a similar spirit as we do, I would be very interested to find it out. Yeah.
Thanks.
Okay, and then we have Chris there online. Did you get him up?
Right. Can you hear me and see me?
Yes, both.
Yeah, good. Yeah, thanks a lot for a very interesting talk. So my question is sort of about the methodology of measuring sort of moral motivation. So here, as I understand it, it was about actually a survey about how judgments, right? And it was not about moral behavior. And then, of course, there is an issue about, first of all, about the honesty of the answers when it about people's morals. Of course, we want to show that we have, or tell ourselves that we have a civic duty and take it seriously and so on. And secondly, also, even if we're actually honest, there's a gap between motivation and action and our moral values, which have been shown in other sort of areas, of course. So if people are concerned about this sort of unintended negative consequences, they might be more concerned about the lack of then pro-social behavior rather than the lack of expressing pro-social judgment, which might be honest or not honest.
Yes, I totally agree. And this is one of the reasons why we try to look at behaviors like the second shot uptake and the third shot uptake. And we also introduced this donation question. That was, trying to get a little bit closer towards behavior where you actually put some money on the table or you donate some of your money to this charity. That's at least taking it a little bit a step closer, I think, to kind of a behavioral outcome rather than just an intention. So that's why we try to look at vaccination uptake for the third or second and third dose, plus these kind of incentivized questions on donations. But I agree that in our case, we didn't find anything for any of those, but I agree that, of course, in the end, I think most people are concerned about the behavioral changes that these potentially moral changes might lead to.
Happy with that, Christer?
Just to add, yeah, so it is getting a step closer, but of course it's still a big step left because it's still just sort of answering a survey about what you would be willing to do. And of course, we know that's a big gap between that and what you actually will do. And of course, also there was a general idea about civic duty, right, which is measured but just by asking people.
Yeah, no, sure. Some of these things, like the risk and also the civic duty, we cannot, get a clean behavioral or incentivized measure for. But I think the vaccine uptake is probably the only true behavior in some sense we have, but that's also indicative that it's not leading to, at least in this domain, any changes in behavior.
Good, yeah. And I guess there might be ways to actually have proxies for that more civic duty behavior too, perhaps, possibly for future research.
What would you think? I mean, I'm all ears to any suggestions.
No, I'm just sort of thinking out loud here. But
no, I think that's a good point. And I think if I were to redo this, I would probably ask for consent to add register data. We can get some stuff there potentially when it comes to at least potentially voting behavior and charitable contributions from the tax authority. That would be potential measures where, I mean, now I don't think these 200 kronor would crowd out, maybe voting, but at least it would be a behavioral measure, right? So that we could consider for researchers could consider for future work as kind of proxies for civic duty and using real behavioral data.
Thank you.
Now somebody who can implement this maybe later on. Maja.
Thank you so much, Maja Fiesta. I think I have one question and one suggestion for future research. The question is, sometimes we use economic incentives to change a social norm. You describe, of course, that the social norm was already to get vaccinated. But for example, in paternity leave, we try to increase social acceptance of going on paternity leave. And if you sort of live in a community when paternity leave is generally considered as silly, that is a very small community in Sweden, of course. But then you can always point to the incentive and say that, oh, look, but we won't get this money if I'm not on paternity leave. And I guess this cannot be seen very well in the Swedish data, but it would be interesting to hear you say something about the American data if payments increased social acceptance of getting vaccinated. And the suggestion for future research, adding on very interesting first question raised by Valeska, of course, this we were always afraid of introducing incentives because we think that will create an expectancy. And this sort of tragedy of expectancy is well described, I think, in policy. For example, I think 15 years ago, we introduced a grant for replacing an oil furnace with some sort of sustainable energy and for a limited period of time, and everyone was afraid that when this time is over, no one will throw away their oil furnace because they will wait for the next time when this incentive is in place. And that is, of course, interesting. And I think possibly the most interesting policy implication in your data is the tendency to get the flu shot next year in this crowd that got an economic incentive the first time. On the other hand, the people that get a flu shot is not a representative strata of the Swedish population. Also, the blood donors, which you also has as an example, they're a hopeless crowd. I've been trying to use antibody data from blood donors, and they're highly educated, mostly women. They really do not represent the population. But it would be interesting to follow this group of economic incentives for vaccination and see if they sort of suffer from this tragedy of expectancy in other health intervention that are less particular than flu shots and blood donor. Thank you.
No, I totally agree. I mean, it would be very interesting to have other context. I mean, we tried to think deeply about what context, of course, and these are the ones we came up with because we thought they were, maybe we thought a little bit closer, there is a bigger chance that you find potentially negative effects of it. So that's clearly something that we could think more deeply about. And I totally agree with the point that, incentives can potentially also shape norms. And I actually thought that maybe, in particular in certain neighborhoods where there is a lot of skepticism against vaccination, maybe, I'm not saying we should do this, but if you would have paid a large amount of people or enough amount of people to get vaccinated, maybe they would have learned, that this was not so dangerous, for example, and you could have, a positive norm effect rather than a negative norm effect in those areas as well, if it works out fine, which it typically does for most people in this situation. So clearly you could think about, this kind of shaping norms.
You also make the argument, which I think is very interesting, that paying people indicates that it's a sacrifice to get vaccinated. And that I think is also interesting. Which social norm are we shaping by incentives?
Yeah, no, I mean, that's another way of thinking about it, perhaps, that it is a sacrifice. So maybe people will start to see it as a sacrifice or something that's more costly than it is, right? Of course. Yeah, these expectations, I think they might be there. We don't find much of them, at least in our data, it seems. I mean, that's the only, scientific answer I can give based on our studies, is that we don't find much of those expectations. And that could be potentially due to they knew this was a research study. there you might have a different effect, of course, if you saw that the region or the local authorities started to pay. I mean, you might get more of the expectations than if you know that you were just lucky to end up in this researcher study. So that could be a potential caveat towards our estimates, of course. But
just follow up on that. I mean, we talked a little bit about it already during the talk, but I mean, you're focusing on money.
Yeah.
And money has all this kind of symbolic value. So it would be really interesting to compare it to, that you can give, something of the same monetary value, chocolate box, something like that.
I agree.
And also this other thing to work on people's, respect or esteem by giving medals or something like that, and compare that, because they don't have the same symbolic value that you seem to worry about a little bit, that they can, other people are worrying about. So then one can just replace it with something like that.
No, I agree, and I guess that's why if you give a blood donation, you don't get money, but you get a sandwich or a mug or a bag or something. It might be actually worth 200 kronor sometimes, but it's not perceived in the same way as money. But I should be totally honest with something which I haven't mentioned, is that this was not money. It was like a super presentkort. So it was as close as we could get to money. And that's clear from the publications. I just forgot to mention it. So, I mean, but it was framed as money throughout the whole experiment. So it was only about kronors. It was only, you will at some screen at the beginning.
There was some cash in an envelope.
Yeah.
But especially when you talked about immigrant neighborhoods and things like that, they kind of, if you want to signal something about esteem or being an upstanding citizen, that then might be better with a medal or something to put on the wall.
Yeah, if it's perceived as the right thing. It's not clear if you're in an area where it's not perceived to be the right thing to do, whether it brings prestige or esteem to do it. I mean, that's it's an open question. But
Joe. Online.
Hello.
We can't hear you for some reason, Joe.
Can you hear me now?
Yeah.
Oh, okay, good. So I want to ask you about a reaction I had when I thought about the initial incentive that it's 200 crowns. It seems to me like people who are sensitive to a 200 crown incentive were assigning a kind of low value to the vaccine to begin with. My reasoning being that 200 crowns was a difference-making amount for them, and if the value of the thing was equivalent to many thousands of crowns, then it wouldn't make a difference. Like I wouldn't make a marginal decision to buy a car based on a 200 crown incentive. So my thought is, well, firstly, do you think that inference is sound? And I guess secondly, I don't particularly like this way of thinking about things, but if you think about like a value of statistical life kind of way of evaluating risks, it seems like we're learning something interesting about how people perceived COVID risks and the vaccine benefit in terms of risk reduction. This is maybe self-congratulatory, but I don't feel like it was a 200 crown decision because it felt like it was a really important health decision. So do you think we're learning that for some people it was a kind of relatively marginal thing?
yeah, I think we learned that there is this between 4 and 10 percentage points of the population. For them, it's not can do it if I get the opportunity, or if I get into the mood of doing it, I'll do it. But it's not something that they apparently seem to value very highly. I think that's for clear. Whether we should think about it as a sort of a calibrated, well-calibrated decision where they weigh 200 kronor versus the increase in qualities or expected life, that's I'm not totally convinced, but of course there might be an aggregate something like that going on, but I think this is more of this is my speculative interpretation, which I don't have much evidence for. It's more like attention grabbing effect to some degree. You get these 200 kronor, it sticks out, and why not take this opportunity, and I do it rather than, and I think that's. Why do I think that? Because we don't have any heterogeneous effects. I mean, if you were really thinking about this as some sort of calibrated decision, it seems like you would get less, effect in a very high social status environment with lots of money around rather than in another context. But that's just one interpretation. But I agree. In theory, we should be able to, if we just knew the risks of those people, or if we knew the risk perceptions of those people, we can potentially back out, some measure of how do they value this change in their health status.
Happy with
Yeah,
that?
thanks. I guess I'm not proposing that we use it to measure their sort of value of life or anything, but rather that I wanted to make sure that I was sort of reading that the right way. Yeah, thanks.
Emma, you had a finger on this?
Yeah, just a slight one. Maybe this is related to their ages, like their risk of getting COVID. I mean, in relation to Joe's question.
Yeah, the thing is that we don't find so much of those things, and that's why I was a little bit speaking against this interpretation as a well-calibrated, issue, because for most young people, the effects were kind of negligible in some sense, right? Would be, at least if you're 20 and you're, healthy, I mean, the risks are very low to start with, but they were as likely to reject two incentives as someone that were more older and probably faced a higher risk.
Yeah, thank you.
Very good. See who's next on the list then. Tim.
Yeah, thank you very much for your talk. Oh, thanks. I had a question about the winter 2022 study, the choose your own incentive variant. So my understanding is that you weren't looking at, for example, whether certain salient groups within your initial 5,000 survey respondents responded differently to the different incentives. You were just looking at whether, like, any of these other incentives that you introduced might compete with the 200 krona incentive, right? So you weren't looking at, for example, whether like people who identified as risk-seeking were like more likely to choose the lottery than the 200 krona, and whether that had more of an effect on them than the 200 krona option. But I just wondered, like, is that something like you could do? This is moving toward like a targeted incentives.
No, sure. I mean,
kind
that's a good point. I was very brief on this paper, and it's also because it's the most preliminary work we have. But it's there. We did look at, can we predict their choices based on those in the choice condition? Can we predict those choices based on those preferences? Yes, we can. So those that are more pro-social, they are more likely to pick the donation treatment than, let's say, the 200 fixed payment treatment. So that's something.
But when you looked at the effectiveness, you were just looking at the averages.
Yes.
For the whole group.
Yeah.
But you could also have looked at the effectiveness for the targeted groups, right?
Yes, we do find some differences there, but they are not strong enough, to make it worthwhile to throw the risk-seeking people into the risk condition instead of the fixed payment.
Okay, and that's not just because the groups are like too small when you break them up.
No, probably
okay,
not.
Yeah, cool. Thanks.
Alexandros, a follow-up.
Yeah, so very related to this, especially about the risk treatment, you chose a very particular lottery to use, which sounds like you win with 1% probability, sounds very low to me. And I mean, we know that people have weird attitudes with respect to probability. What about if you gave them 10% to win a tenth of the prize? Do you think that might work better for that?
Then the expected value is bigger than 200.
The same expected value.
Oh.
Yes, so now we kept the expected value constant. That was one of the of course, ideas, to not mix those. And then going as close as we could, basically, towards the US case, where they had much lower probabilities. And, of course, from the standard Kahneman-Tversky framework, you would think that the smaller the probability, perhaps, the more they overweight this probability. So therefore, it might be more effective to introduce a small probability with a large price rather than something like a 10% probability.
Thanks.
So it depends
Happy with that?
on what.
Okay.
There is this psychologist claiming that we tend to overestimate the rare events, right? So.
Erik.
Thank you. So, first a comment. I think the mechanism interpretation in terms of attention grabbing, I think that makes a lot of sense, and I think that's also an interesting way to argue against the concerns that have been raised here that there will be general equilibrium effects or long-term effects. That if it is indeed an attention effect, then it's at least it would be a different argument to say that, okay, people come to expect this. It would be that they expect not the monetary compensation, but they expect to be have their attention grabbed. And then you can think of other perhaps ways of grabbing attention. But the other thing is more on the context of creating this research. You alluded to it at some point when you said that you had to work against the clock to get ethical approval. What, in your experience now, is in the Swedish research system? What is good and what is bad when you want to try to create something, a large-scale, high-impact study at a short notice? I don't know if we have Stefan here. No, he's not here. Otherwise, you could take the views directly to Vetenskapsrådet.
I think that's I mean, the attention story and why we don't find it, or that could be an argument against his concern. I think that's a very good point. I agree that if it's only attention, then I mean we're probably less concerned, particularly about coercion and those kind of things, but also perhaps expectations. When it comes to the sort of general situation for doing this kind of research in Sweden, I have a few remarks, and I've made one of them semi-public at least, and that's that the Swedish system for university funding doesn't work in these situations. So this is the first studies we managed to do on one of my grants where we could squeeze it in, but then it was against what I promised to do. But the big studies here was more or less fully funded by US money. So these co-authors, I mean, we shouldn't compare. They are University of Chicago and Columbia University, so of course they have different resources. But it is interesting to see how much money or the sums of money they can get at short notice to when there is a potentially interesting study to be done. So these studies would not have been made without US research funding. I mean, that's clear. So that's something we should have in mind, maybe have some seed money or, kind of research funding, which is for specific projects that maybe now, you have lots of interesting stuff going on with electricity, and there's a lot of behavioral stuff you could think about there, also about expectations. What are people's expectations now when you introduce, this support to household for electricity last year, and everyone says, no, it's no problem, it's for last year, but don't people form expectations about behavior for, or, whether they're going to be compensated for this year's? I mean, that's studies that we could also look at if we had money and resources to do quick, that could be done in a couple of weeks, to try to figure out those kind of things, which are very policy relevant, right now. So I think we should have better, support and quick funding for policy relevant research that's urgent or needs to be addressed urgently in order to, get proper data or good data. So whether that should be Vetenskapsrådet or whether it should be at the university faculty level, I'm not sure, but somewhere, because my impression is that when it comes to then the research council, even if they are quick, they are not quick enough. So that's my worry, because they have to put into a committee, they have to, do it the proper way, which has for good reasons, but it will still be a little bit slow compared to the kind of funding we got, where the professor knocks on the office of the dean and they get the money the next day. I mean, you cannot compete with that. But then of course, I mean, there are pros and cons with the different ways of channeling this money. But I'm a little bit worried that if you put it into the hands of the research council, it will still be a little bit too slow potentially. But there is probably scope for both, but that would be my. And then it's of course the issue with cooperation with the governmental agencies like Folkhälsomyndigheten and so on. There, I think we also have room for improvement, right? It's not easy. I mean, in the end we got the data, but it's not like we can talk or we got into contact, with someone that was genuinely interested in, trying to figure things out, and I think other researchers in Sweden have found the same when they tried to do the mask study. I think they tried to do it in Sweden. It ended up in Bangladesh in the end, and that was kind of, I don't know the full story there, but the impression was that they also had, they didn't get some sort of support or any contacts there to push it further. I could also understand, of course, that this was during a very specific point in time where there was a lot of stress in these agencies. So it's clear probably that their first priorities was probably not to help or to collaborate with researchers. But it would be good if next time something like this happens, we would be more prepared, to initiate and support those kind of collaborations. So more funding, more openness, to collaborating with researchers, and I think. And everyone else, I mean, it would be interesting to hear if anyone else on what's the take on these issues in general.
Happy with that?
Yeah, no, I agree about the mask study. I mean, I know Martina, who was also involved in that, and they were really trying to get the attention of Folkhälsomyndigheten, but didn't. So, yeah.
Very good.
Yeah, I guess in this situation it was particularly, let's say, concerning because there was this emphasis on getting evidence, right? But if we are relying so much on getting proper evidence, then we should also be supporting the collection of that evidence, right? I mean, otherwise it seems like I don't know, it's not really coherent.
On that note, join me in thanking for this great talk.
Yep.
The last research seminar for this term, we will start again end of January or early February, so you're all welcome then. And otherwise, from me to all of you, happy Yuletide.
Thanks. Great seminar.